Hi, my name is Jason Yuen. I'm from Mayo Clinic, Rochester, Minnesota. Thank you for the opportunity to present our study titled Comparison of the Impact of Skull Density Ratio to Alternative Skull Metrics on MRI-Guided Focused Ultrasound Thalamotomy for Tremor. I have no disclosures. MRI-Guided Focused Ultrasound is increasingly being used as treatment for essential tremor. In particular, it's a minimally invasive treatment as an alternative to deep brain stimulation. Essentially, MR thermography offers accurate temperature measurement during the treatment. Usually, we target at between 55 to 60 degrees Celsius. However, in certain patients, there are significant technical challenges in achieving this temperature. Therefore, we need a good predictor to see which patients are more suitable for this treatment. One such metric is skull density ratio, SDR, which is currently the most commonly used metric for MRI-guided focused ultrasound. The threshold is usually set at 0.4, below which the patient is considered unfavorable for the treatment. Essentially, it measures the density ratio between the cancellous bone to the cortical bone. However, previous studies have suggested that an SCR less than 0.4 does not necessarily lead to a better long-term outcome. To better understand that, we have to think about how the SCR is being measured. So essentially what happens is that an imaginary line is usually drawn from the sonicator to the target, and within that area of the bone traversed by the line, SCR is measured by comparing the Hounsfield units between the cancellous bone and that of the cortical bone. And by averaging the values from each of the 1,024 sonicators, global SCR is being measured. So we did a literature review, and it shows that the SCR correlates with the maximum temperature and the maximum energy and the maximum power in certain studies, but the correlation is not very strong. So we need a better predictor to predict which patient will be treated better with this modality. So the objective of our study is to develop a regression and classification models to predict maximum energy, power required, and maximum temperature reach in the treatment from a combination of patient metrics. So we did an electronic health record review of 62 patients in a single center that are treated in 5 years. All patients underwent unilateral MRI-guided focused ultrasound targeting the ventral intermediate nucleus of the thalamus. So the data collected includes the patient demographics, such as age, gender, skull metrics, and the treatment parameters as an outcome. We use a number of standard machine learning algorithms to try to predict the outcomes using those inputs already mentioned. Each model was assessed using a 5-fold cross-validation due to the relatively small sample size. So overall, with 63 treatments among 62 patients, and the average SDR is 0.5, and the majority of patients are male. So we first separated the two groups into those with SCR less than 0.4 and those SCR more than 0.4. And we showed that the maximum energy, maximum power, as well as the maximum duration are more favorable in those with SCR more than 0.4, which supports our use of SCR equal to 0.4 as a threshold at the moment. SCR also has the strongest correlation for maximum power, maximum energy. But if you use the local SCR, which, as I said, is the SCRs that's from each sonicator that we use to average out to find the global SCR as a predictor, it actually gives a better prediction for maximum temperature as well as maximum duration of each sonication. Using the machine learning algorithms, we showed that essentially adding more information from the local SCRs, as well as age, gender, actually gives a better prediction of the outcome in terms of the maximum energy, maximum power, and the maximum temperature. Overall, this is a single-center retrospective study, and our sample size is relatively small. And also other factors such as skull geometry and the incident angles are not included in the study and should be considered in future studies. And we need longer-term clinical outcome to validate the benefits of our models. In conclusion, the global SCR is a perfect predictor of treatment outcome, but alone it had a superior correlation with these key parameters. Combining data from the local SCR as well as demographics gives a better prediction for the maximum energy and maximum power used. The evaluation of alternative skull features may be helpful to improve prediction of treatment parameters and help to facilitate patient selection as well as patient counseling. So the references. I'd like to thank my co-authors, particularly senior author Dr. Vance Lehman, for his help on this paper, which is published in the Journal of Neurosurgery recently for those who are interested. Thank you very much.